All right, so now we're going to start the module where we're talking about intubating and ventilating neonates. And it's nice to have the adult background where you can compare everything to it. One thing you notice about neonates is they can be doing fine, and 20 seconds later, they can be cyanotic and not breathing, or they need a little bit of oxygen. You give them the oxygen and now they're doing great. So they deteriorate and improve much quicker than with adults. With adults, we can see respiratory failure coming probably hours or longer before it actually happens. Usually we have time to get a blood gas, try different types of therapy before they actually get intubated. And neonates, it's really quick. The fact that they can turn around and deteriorate so quickly. All right, we start off with intubation, and intubating a neonate. How do we choose the proper size for the laryngoscope blade? And it gives you a list here of the sizes to use. And it says straight blade only. So because with the Macintosh having a curve to it and the large tongue in the neonate's airway, the Macintosh really doesn't move the tongue out of the way, but a straight blade does. When you push up on the tongue, it's going to move that big tongue out of the way better. So that's why you're not going to see a Macintosh blade used with neonates. And then 00 is for the extreme preemies, 0 for preemies that are about 2 pounds. And then a term infant uses a laryngoscope blade size 1. And once they're about a year old, you may even need a size 2. And when choosing the right blade size, it's whatever fits to the back of the tongue, and you can lift the tongue up. So if you put a blade in and it's not getting all the way to the back of the tongue, that's what makes you realize, okay, I need a larger blade. So rather than just memorizing a table, just keep that in the back of your mind when choosing your laryngoscope blade. All right, for choosing the endotracheal tube size, you choose an endotracheal tube that is cuffless, and it's cuffless because the cricoid cartilage is really close to the endotracheal tube, and it doesn't really form a seal, but it's good enough. So with the cricoid cartilage being the narrowest part of the airway and it being really close to the endotube, you don't get too much of a leak. So therefore, a cuff is not needed. And so that's what, 10 years, 20 years ago? The American Academy of Pediatrics no longer recommends uncuffed tubes only. So it doesn't mean that you can't use a cuffed endotube. It's just, you know, the habit of many, many years, and still you'll notice with an intubation, the intensivist wants an uncuffed tube. Then if tracheomalacia is developing and you can't get a good seal, then they'll switch over to a cuffed tube. So I wrote cuffed tubes are usually used after there is a big leak around the cuffless endotube. So the babies would have to be re-intubated with a cuffed tube. Smallest tube there is a 2.5, and that's what's used on the preemies. And then as they get a larger leak, then a larger tube is used up to 3.5 millimeter. 3.5 millimeters seems to be like the number that you want to stick in the back of your mind. If someone says, what size tube do you want to use to intubate a neonate? Think 3.5 off the top of your head. Then from that, think, oh, wait a minute, is it a preemie? You know, what does it weigh? Oh, okay, less than 2 pounds. All right, then we would recommend a 3.0. If they are closer to a year old, then a 4.0. So use that 3.5 as the number that sticks in your mind. All right, and then it shows here the suction catheter size that you use for the different endotubes. It's really hard to get any secretions through a 6 French suction catheter. It's so tiny. So if there's thick secretions, it just doesn't come up that suction catheter. So that's one of the challenges with suctioning with a 6 French. But that is the size catheter that you use. What did you learn in your equipment class as far as choosing suction catheter size? Was there a formula? Was it like half the diameter of the endotube? Tidjin?
The ET2 times 2 and then -2.
Okay. So ET tube in millimeters. All right, so 2.5 times 2 would be 5. Minus 2
Yeah, it was 3 minus
is 3.
That works for adults, I think. Like, okay, like ET tube size 7 times 2 is 14, so you use a size 12
Okay,
French. Yeah, that works for adults. I don't know what the.
all right, so it's not working for this one. How about just twice the endotube size? It looks like it'll work. If the middle here is 3 and you're using a 6 French suction catheter, that would work. Here, if you use 4 times 2, an 8 French suction catheter. And this one, we got to stretch it a little bit. So 9, we have to move up to 10. Is that a good way to remember it? So there's preemies, full term, 1 year. Preemies, 6 French. Full term, 8 French. 1 year, 10 French. When babies are older than a year old, there's another formula you can use to figure out the correct size endotube. And the formula is given to you. It's age over 4 plus 4. So let's say we have to intubate a 5-year-old. No, that's going to give us a, how about a 4-year-old? We're going to intubate a 4-year-old. What size endotracheal tube do we use for a 4-year-old? So it's their age divided by 4. So 4 over 4 is 1 plus 4. So we would use a 5 millimeter endotracheal tube. So what if it's an 8-year-old? What size would we use? Very good. Okay.
I have a question kind of about the ET tubes,
Mm-hmm.
about the way they secure them. I noticed I'm in PICU and Broward and they're all secured with tape, even patients that have been there a long time. So I asked the therapist, like, we were changing out the tape and I said, why aren't we putting like some sort of anchor fast on instead of tape? And she said that they don't make them for kids that size. It was like a 2-year-old. She said they have them for like infants. And then they have them for older kids, but for some reason they don't make them for this size.
Oh my
And I was
word.
like, oh, I'm like, is that just like a Broward thing? You guys don't have them or they don't make them? And she was like, I don't think they make them in general, otherwise we'd have them. I was like, oh.
Very
I was wondering if
interesting.
that was true, if anyone else sees.
I'm Memorialist tape also.
Tape also? That's so weird, like why?
So if somebody made that.
And they have a lot of those secretions for tape. So.
Yeah, it is so gross, and like this baby had such bad skin breakdown from the tape, it was horrible.
That's interesting though. Why would you not make
anchor fast for the pediatric population as well, like.
Right, you make them for babies,
And
maybe
adults,
it's just
more
supposed to be not
secure.
between. So I was just wondering if that was true, I guess it is, if you see it on the.
That's interesting. I mean, it's called terrible twos, right? Maybe they're trying to. do
And tape works the best.
that.
No,
They
I
could.
don't think that's it, I mean, this patient, I mean, they have them, restrained, sedated, so it's not that.
I have some notes on this slide. One of it says, with cuffless due to cricoid cartilage, an air leak will occur. This will affect ventilator graphics. This will affect pressure support breaths. So I'll put that in the chat. So it will also affect pressure support breaths. Tell me, how is it that if you have a leak around an endotube, is it going to affect pressure support breaths?
It's gonna set it off as the fear initiating the breath.
Oh, yeah, it affects, it causes auto triggering. Yes, that's true. But how does it affect pressure support?
Doesn't it give you more pressure?
There's more resistance.
How does pressure support end? How does
Breath is
inspiration
delivered.
end?
No.
No.
Oh,
So what is inspiratory cycle?
When the percentages of breath.
When those two
breath
Does
ends is when
anyone
it
know?
terminates.
So ventilator, like when the exhalation, the flow is decreasing, and it has to sense like, oh, this percent of flow is missing, now you can cut off the breath. But since there's no cuff, the leak, there's so much air coming out of the vent can decide when to full cycle off.
So pressure support ends when flow diminishes. Pressure support ends when flow diminishes.
But if flow never diminishes.
It would just never stop, right? That would be like, CPAP.
Pressure support breath ends when flow diminishes. If there's a leak, flow doesn't diminish, breath doesn't end. After 5 seconds, the ventilator will shut off, then open up exhalation. But that's the problem with a leak, is pressure support breaths don't end. You can increase your percent cycle off to kind of compensate for that. All right, so did that jog your memory? It's a really important concept. You come across it all the time, especially with neonates. If you see these really long inspirations, about 5 seconds, you know that their pressure support breaths are not ending because of the leak around the cuff. So yeah, make sure you know that. What else have I got? Okay, and then I have a scenario. A 2-year-old requires intubation. I want to know what size endotube. What size blade? And what size suction catheter? All right, so 2 years old. What tube are you going to grab out of the roll pack? How did you come up with 5? Okay, so 4.5, so age over 4, so 2 over 4 is 0.5 plus 4, so 4.5 endotube. When we grab the laryngoscope, which blade do we want? A size 2 or 1 or 2? Did we say 2? Yeah, 1 to 2 for a 1-year-old. So yes, a 2. And what size suction catheter for a 4.5 tube? 10 French. Very good. So it'll be like that on your next exam. You know, this is the age of the person. Figure out what tube you'll use, what laryngoscope blade, and what suction catheter. It says distance to mid-trachea from gums. So lip to tip. This comes from American Academy of Pediatrics. And pretty much what is the lip mark when you're intubating? So of course, if you never saw this slide and you remember that when you're intubating, you want the tip of the tube to go past the vocal cords and then you stop, you're good to go. So that's how you should be intubating. And then this is just a guideline that, you know, you're probably in the right area if. Does that make sense? So when you're putting an endotracheal tube in, you don't say, oh, I'm intubating an adult, and you start sliding the tube in, and when you see 23 at the lip, you stop. No, you're doing it wrong. If you're doing that, you put the tube in and you're visualizing the cuff going past, for adults, the cuff going past the vocal cords. And once the cuff is past the vocal cords, you stop. So you're not intubating according to lip mark, because some people are 6 feet tall, some people are 4 feet tall. They don't all get a 23 lip mark. It's going to depend on how big the person is. So you go according to, okay, the cuff is past the cords. Now let me see what the lip mark is. And that's what you record, is what your lip mark is at that point. Secure it, and that's when you get your x-ray later to verify that your tube is in the right position. So that first, so that comes first, and then the slide that says with neonates, typically the lip mark is going to be their weight in kilograms plus 6. So if they are, what does it say here? 1,000 grams, they're 1 kilogram. So 6 plus 1 kilogram is 7. Their lip mark will be 7 centimeters. Around 7 centimeters. Could be 7.5, could be 6.5, but around 7. And then another example is a term infant that weighs 3,000 grams. That would be 3 kilograms. So 6 plus 3 kilograms is 9. Their lip mark will be about 9 centimeters. And then for pediatrics, it's 3 times the endotube size. So in our 2-year-old that we intubated with a 4.5, what should their lip mark be, approximate lip mark be? We intubated with a 4.5. So 3 times the endotube size. 3 times 4 is 12. And then we have 1.5. So like 13.5 at the lip. You want me to put that in the chat? Okay. So internal diameter of the tube times 3, and if we intubate it with a 4.5, it's 13.5, so the lip mark will be approximately 13.5. Okay, and then in my notes I have in preemies, the slightest movement of the tube can cause the endotube to come out of the trachea or go into the right or left main stem bronchus. So I'll put that in the chat so you can write it down. But their tracheas in preemies are less than an inch. And you've got the tube in the middle, so you've got very little movement, just one little turn of the head, or you're in the mouth, cleaning the mouth, and you move the tube slightly, it can come out. So it's like very small room for error in the preemies. As far as the tube going down too far, with adults, when the endotube is down too far, where does it usually go? Right main stem. In neonates, the angle of the left main and the right main are about the same. So they branch equally. So when the tube goes down, it has a 50-50 chance of going into the left or going into the right. So that's a little bit different than adults. Got that? All right, this is just a practice chart for you when you're preparing for your exam. You can go in and fill this out. So it gives you a newborn that's premature, a term infant, a 1-year-old. You have to pick the size of the endotube, the depth of approximate depth of insertion, suction catheter size, blade size. And then for neonates, what suction pressure do we set on the vacuum regulator? And that's pediatrics, yes. And neonates at 60 to 80. So I don't know if it's just like with adults where you learn the textbook and then you get to the bedside and you never see what the textbook said.
It just like,
That was my question. I was wondering if they had more sensitive regulators on the suction in pediatrics.
More sensitive there? No.
Or
Like it's limited to that.
or specifically than just open or closed, like it is in adult ones.
Yeah, adult ones should not be open or closed. There should be a way to set,
Well,
the suction.
kind of, but it's just usually just all wide open.
but it's wide open because the person sets it that way, right?
Never seen it used by like.
Wow,
It's
Okay.
we're used to it.
that's too much information right there.
which is actually pretty dangerous.
Yes, it really is. It sucks the mucosa. When you see a bronchoscopy of somebody that was suctioned on full line vacuum, their mucosa just looks like raw meat because it's so strong. Full suction is very strong. And it pulls on the mucosa and causes some bleeding. So I know with using the Ballard inline suction catheters, a lot of the power of the vacuum is lost in those valves. So to actually suction, you need like 160, not like the 120 that's recommended. But to go beyond 160, yeah, that's pretty.
How high does the suction vacuum go? Like, what's the max?
I think 200 millimeters mercury is maximum suction.
Oh. So we're suctioning neonates and adults all at 200, and that's way above. Oh. Okay.
Yeah, not good.
In Broward, they have them on full for the meetings.
Yeah.
Yeah, that's not good. That is not good. Okay, I have a bunch of notes on this one slide. So head position of the neonate for intubation. We don't hyperextend like we do with the adults because their airway gets occluded. So hyperextending the neonate, you occlude their airway. So you do use sniffing position. So head position for intubation. Sniffing position, avoid hyper extending the head. So sniffing position, how do you get the head into sniffing position? Sniffing position is when the head is forward and up, like you're smelling a rose is how it was described to me, that's sniffing position. So how can you get your head like that? You know? Could you roll a towel up and put it behind their head and their shoulders?
Yeah, behind the shoulders.
Yeah. Yeah, so behind their shoulders, is that going to hyperextend? So you be careful with the amount of towel you put underneath their shoulder. So that was for head position. And then for securing endotracheal tubes. I have used the neobar or the new neobar. Or what do they call that? The neo something. Shoot, I have it written down as 2-block. It's not called 2-block. It's what they use at Broward. Do you know the name of it, Karinja? What they use to secure the endotubes? It's the neo something. The neobar edge OD. All right, it's right here. Neo fit. Neo fit. It's the one that I think you guys called it. It looks like the anchor fast. As the metal digs into the endotube. And then you stick the rest of the face. So the Neo fit. So either the Neo bar or the Neo fit. And then you use Mastisol on the skin. It helps the tape to stick and it protects the skin. So I'll put all those notes in. So I wrote for neonates, secure the endotube with the neobar or the neofit. Use Mastisol to protect the skin. There's an extra G in there. From the adhesive. Okay, and then I have do not wrap tape around the head. So with adults, we go all the way around, we secure the tube. And with neonates, you can't put any pressure on the vessels in the neck. It causes head bleeds. It impedes venous return from the head, so it increases pressures. So we can't put tape all the way around the neck. Neonates, pediatrics, you tape on the face only. And then I have trim the tube 4 centimeters from the lip according to AAP. So why would it be important to trim the endotracheal tube? If it's properly in place, you have your x-ray to verify your lip mark with what you see on your x-ray, and you've got all this extra endotube sticking out. What would be a reason to trim it?
Because it's too long. Because it's not covered.
Oh, for like safety purposes, if it's too long?
Like if you put it on his bands and you know.
Kinks.
Section and everything, and kind of things.
Okay,
Somebody gets, if you get the tube on, they can pull the tube out.
okay, yeah, so for safety reasons. That's a reason. And then the other reason is because of airway resistance. The tubes are tiny to begin with. And if they're really long, that's a lot of airway resistance to have to breathe through. So trimming the tube will minimize the airway resistance of the endotube. So trimming the endotube will minimize the resistance of breathing through the tube. And then that can be dangerous because if you see the tube hanging out and you think, oh my gosh, I'm going to trim that. But what if you didn't check your chest x-ray and you didn't notice that the tube is up too high and now you've trimmed it? Now there's no way to push it down and advance it. So that's why 4 centimeters is what, like 2 inches, having it out 2 inches. And that way, if you do have to advance it, there's plenty of room to still advance it. So that's one of the cautions of trimming an endotube. I would make sure that, especially when you guys are new and you're starting out, don't trim the endotube unless you've checked with your supervisor first. Because you just don't want to be accused of anything like that when you're first starting out. Okay, and then for checking for proper placement, I have that breath sounds are transmitted very easily, even with a main stem intubation. So tube is in, you listen to breath sounds, you hear great breath sounds on the right, on the left. And then you get your x-ray and you see that the tube is down in the right main stem bronchus. How does that happen? And it's because the sound transmits so easily in those little tiny chests. When you're listening to the right, you're hearing the sounds on the left. So that's why a chest x-ray is so important. So I'll write down breath sounds transmitted very easily, even with a main stem intubation. And then on chest x-ray, what are we looking for good placement?
It's between the second and third.
Second and third rib.
Or the second and third rib side, yeah.
And then also below the clavicles is another way. Or a half a centimeter above the carina. All right, as far as suctioning via the endotracheal tube, are you doing it with adults where you don't hit the carina? Like you pass your suction catheter and you don't simulate a cough, you just suction what's in the tube?
Not all the time.
Most people go down.
And hit the carina?
and hit the curve. That's what I see.
Okay. That's been standard practice since I started the profession. And in neonates, it was like, no, you do even just like one time hitting the carina, you're damaging the mucosa. So never let your suction catheter go past the end of the endo tube with neonates. Then I heard that being carried over into adults. But never hitting the carina and never inducing a cough in adults. I'm just wondering if there's any studies that show that there's a lot of mucus accumulation, because if you don't stimulate a cough, it just sits in the airways. So, yeah, I'm just wondering what you're being taught. All right, so suctioning via the endo tube. Don't advance the catheter past the tip of the tube.
In the bill, can we suction? When you go past the end of tube, it goes a little bit past the end of tube, right? The suction catheter?
With the adults?
Yeah.
If you go down to the carina usually, right?
So we're actually putting it in. Oh, I didn't know.
Yeah. Yeah, when you feel a resistance to the catheter moving any further, you're hitting the carina.
That was just like, I'm going all the way down. It's really easy. I didn't know it was gonna be-
Oh, I see. So when you go all the way down, do you notice the patient starts coughing silently? Yeah, it's because you stimulated a cough when you hit the carina. You didn't know that?
So it's okay to hit it, but not all the time.
Yes. Yeah, once in a while to stimulate a cough. Yeah,
So I think you have to chart that, like.
that should be
diagram,
tracked. Yeah.
you have to chart that, so. But they don't, I don't know if they do that.
With neonates, they don't stop. They don't match up the colors or and the numbers.
Okay, so if you match up the colors, you're getting.
You're not hitting the carina.
Okay.
Yeah. So if you go till you feel a resistance and you're stimulating a cough, yes, you hit the carina. What was I going to write? Don't hit the carina? No. Yeah, don't hit the carina with the suction catheter. Did I get too wordy? Did I get too wordy on you guys? Don't hit the carina with the suction catheter. Instead, match up the numbers on the catheter and endo tube. to ensure your catheter doesn't go past the end of the endotube. So you can cut and paste that if it's too many words. Peds, let's see, Gretchen, are you in peds?
Yeah.
Do you have any trachs in peds? And when you suction, are you told to not go past number 10? With your suction
It
catheter?
depends on the patient. I don't think it's a specific number. It depends like how big the patient is, I think, because I noticed it was different, like a little baby. And then I had like a 2-year-old.
Okay.
They mark like a safe zone.
Oh, they do.
Yeah.
Oh, okay. What about it, Jody?
For the little babies, you match up the colors, and then for the older kids, I just been very sterile suction.
And you just go to stimulate a cough?
Yeah.
Okay. Yes, I don't know why I wrote that, because it's gonna depend on the different sizes of the kids. So I don't know how you can just say, don't go past number 10. All right, I agree. I'll cross it off. Oh, just showing what it looks like for hyperextending the head versus not extending the head enough, called flexion. And then correct extension is the head's extended, but not hyperextended. So that's what it should look like when you are intubating. So the resuscitator bag that you guys use in the lab, you used the flow inflating bag where you have to have a flow and a seal in order for that bag to stay inflated. Are you seeing that in the neonatal ICU? You are?
Only difference is they connect it to the nasal problems. They don't use it.
Oh, that's interesting. Okay. Oh, so they're just using it like CPAP. They're not using it to ventilate the baby. All right, so flow inflating bag. What's nice is that the name fits how it operates. And here you see the bag deflated. Remember how hard it was to keep it inflated? You had to play with the little exhalation port to kind of trap the air in the bag so that you could bag. And then it's got the pressure manometer. And then the self-inflating bag, after you squeeze it, it reinflates itself. So it's always ready for the next breath. And all right, so what ventilating pressure is acceptable? So I have less than 25 centimeters of water, but it's best if you keep it 18 to 20 centimeters of water. So acceptable pressures when ventilating a neonate, keep it less than 25 centimeters of water. Best if it's 18 to 20 centimeters of water. And how fast do we ventilate the neonate? Mm-hmm. 40 to 60 per minute. So it's like every second you're squeezing that bag. With the self-inflating bag, can you, if you have a mask on the port and you hold the mask over the baby's face and the baby is breathing, can you just hold the mask on their face and then they'll get their breaths? With the self-inflating. No, very good. So with that, you can't make the assumption that the baby's able to get their own breaths. You have to squeeze every breath into them with the self-inflating bag. So that's something to remember. And one thing not on here is FiO2. When bagging, what FiO2 do you start with?
100 and then go down 30.
Anybody for room air? Yeah, so you start with 21% and then you just keep increasing it until the saturation is where you want it to be. So 21 to 30% is what I have. Oh dear. So this is the best bet when either giving mask CPAP or ventilating a newborn or a neonate is to use the NeoT. When you're holding the mask over the face, they're getting CPAP. And then when you're ventilating, you're just covering the expiratory port and that'll divert the air into the lungs. So the finger over the port is inspiration. And your pressures will only go to the pressure that you have set. So it's not like you get distracted and you squeeze the bag and now you've got 25 of pressure or 30 of pressure or 5 of pressure. This one, your pressures are always consistent. And you set your inspiratory pressure. How do you set the PEEP on this? You turn which knob?
Oh, it's that little thing on the side, isn't it?
Is this it right here?
Yeah, sure.
Or is this it over here?
That.
Okay. So yeah, that's the expiratory port. It has a blue knob around it. And as you turn it up, you're increasing the PEEP, or turn it left and you're decreasing PEEP. If you're not able to get the adequate amount of PEEP, use more flow on your flow meter. I love this picture because the caption doesn't fit the picture. So here is a mask over a neonate's face, and they want to bring your attention to the fact that you shouldn't touch the soft tissue of the neck and put any pressure on the soft tissue of the neck. But they're putting pressure on the soft tissue of the neck.
Is an example of what not to do?
Yeah. It says, note that fingers do not touch the neck or soft tissue under the chin. Look, it's touching. So yeah, I don't understand why that's labeled improperly. Maybe back in 1999, they didn't know.
They didn't know what they were doing.
Oh, and then this is also incorrect.
So they didn't give us a photo with the correct technique then.
No, they didn't. All right, that's it for the day. Let me stop the recording.